Welcome. In this session, we'll be discussing the non-pupillary block secondary angle closure glaucomas, which are caused by a predominantly posterior pushing mechanism, and among these, malignant glaucoma is the classic example. Malignant glaucoma is also known as aqueous misdirection syndrome or ciliary block glaucoma. As we have mentioned, it is a secondary angle closure glaucoma with a posterior pushing mechanism. It is a rare entity but is potentially devastating, and it typically occurs after intraocular surgery, particularly following glaucoma surgery in an eye with primary angle closure. Malignant glaucoma is more commonly found in whites than Asians. It is called malignant because historically, when miotics were the only anti-glaucoma medications available, this form of glaucoma was not responsive to miotic therapy. Other than following glaucoma surgery in an eye with angle closure, malignant glaucoma can also occur following other surgical procedures such as cataract surgery and pars plana vitrectomy, application of drugs such as miotics, or cessation of drugs such as cycloplegics, and we'll come to the mechanism shortly. Following laser procedures such as iridotomy, capsulotomy, or cyclophotocoagulation, or even spontaneously without any medical or surgical intervention. The pathogenesis of malignant glaucoma is still debatable, but the classic description is as follows. Following the precipitating event, the ciliary body rotates from its normal position to a more anterior position, following which the ciliary processes come in contact with the equatorial region of the crystalline lens, causing a relative block to the forward movement of aqueous to the posterior chamber at the site of this ciliolenticular apposition. Following this block to the anterior flow of the aqueous to the posterior and the anterior chambers, the aqueous being secreted by the ciliary body and the ciliary processes migrates posteriorly into the vitreous, resulting in an increase in the volume of the vitreous, which leads to forward displacement of the crystalline lens, which in turn pushes the iris forwards, making the entire anterior chamber shallow and closing the angles. And in aphakic or pseudophakic eyes, malignant glaucoma occurs because apposition of the ciliary processes against the anterior hyaloid face blocks the forward movement of the aqueous, which is thus posteriorly directed into the vitreous, resulting in forward pushing of the anterior hyaloid face in an aphakic eye or the intraocular lens in a pseudophakic eye against the iris. So a patient with malignant glaucoma typically presents with pain and redness following surgery for angle closure glaucoma either immediately or months later, and typically following a cessation of cycloplegic therapy, which is usually given following glaucoma surgery to prevent malignant glaucoma. And on examination, we'll find shallowing of both the central and the peripheral portions of the anterior chamber, and this is very important to remember, which we have described already in this session on primary angle closure glaucoma. And so we'll find asymmetry of anterior chamber depth between the two eyes. And characteristically, if a patient has already had a peripheral iridotomy done previously, that iridotomy will appear patent. Or if a malignant glaucoma patient who has not had a peripheral iridotomy done previously undergoes a laser peripheral iridotomy following the onset of malignant glaucoma, will not respond to the procedure. And this is also very important to remember. And these three are actually the characteristics of malignant glaucoma, which help us differentiate it from other glaucoma entities. We'll also find optically clear zones in the vitreous cavity on the slit lamp, and elevation of intraocular pressure is found, but intraocular pressure may not be significantly elevated initially, and attempt to deepen the anterior chamber through a paracentesis is met with significant resistance from the posterior segment. Ultrasound biomicroscopy will show forward rotation of ciliary body as well as ciliary processes against the iris, as shown here in this photograph. And there will be forward movement of the crystalline lens or the intraocular lens, along with shallowing of the central anterior chamber as seen here. And ciliary body detachment is often found in malignant glaucoma, as shown by this supraciliary space in this photograph. We can recall here that forward rotation of ciliary processes is also a feature of plateau iris syndrome, which we have discussed in the session on primary angle closure glaucoma. In the early post-operative setting, typically following a glaucoma surgery, malignant glaucoma needs to be differentiated from three entities, all of which causing shallowing of the anterior chamber. And these include pupillary block, choroidal effusion, and suprachoroidal hemorrhage. Patients with pupillary block have high intraocular pressure like patients with malignant glaucoma, but in patients with pupillary block, the central portion of the anterior chamber will be found to be deeper than the peripheral portion of the anterior chamber because of the iris Bombay configuration in pupillary block. And pupillary block is typically relieved by laser peripheral iridotomy, while malignant glaucoma is not. Patients with choroidal effusion have shallowing of both central and peripheral portions of the anterior chamber, similar to patients with malignant glaucoma, but in patients with choroidal effusion, the IOP is typically low, and on ophthalmoscopy we'll find light brown elevations in the fundus, and ultrasound shows choroidal detachment within hypoechoic space between the choroid and sclera. In patients with suprachoroidal hemorrhage, there will be shallowing of both central and peripheral portions of the anterior chamber, as well as elevation of intraocular pressure similar to patients with malignant glaucoma, but on ophthalmoscopy we'll find dark brown elevations in the fundus, and B-scan ultrasound will show choroidal detachment with hyperintense echoes suggesting blood in the suprachoroidal space between the choroid and the sclera. So malignant glaucoma is typically diagnosed when a patient presents usually in the post-operative period with shallowing of both central and peripheral portions of the anterior chamber, has a patent peripheral iridotomy, and there is absence of choroidal effusion or hemorrhage on ophthalmoscopy or B-scan ultrasonography, and shows resolution of the pathology with the administration of cycloplegics, as we will discuss. And these are important to remember to diagnose malignant glaucoma in the post-operative scenario. Approximately half of all malignant glaucoma patients can be controlled with medical management alone, and the remaining 50% require surgery. Medical management consists of triad of intensive cycloplegic therapy, aggressive aqueous suppression, and dehydration of the vitreous with hyperosmotic agents. Cycloplegic therapy relaxes the ciliary muscle ring and pulls the anteriorly rotated ciliary body backwards. And atropine is the drug of choice for malignant glaucoma, which is very important to remember. Atropine should be administered 3 times daily, and it takes 4 to 5 days to take effect. Atropine needs to be administered long term following malignant glaucoma and tapered very slowly. And it should also be administered following surgical treatment for malignant glaucoma. Aqueous suppression is carried out with beta blockers, alpha-2 agonists, and carbonic anhydrase inhibitors, but miotics are contraindicated because they may promote further anterior rotation of the ciliary body. And since in malignant glaucoma the vitreous volume is increased due to posterior misdirection of aqueous, dehydration of vitreous with hyperosmotic agents such as mannitol is indicated. If an eye with malignant glaucoma does not have a patent iridotomy, LPI should be done to relieve associated pupillary block, although LPI does not treat the malignant glaucoma itself. And LPI should be as peripheral as possible to avoid ciliary processes and anterior hyaloid which create the block to allow aqueous to drain anteriorly through it. Posterior capsulotomy along with an anterior hyalotomy can be done with an Nd:YAG laser in aphakic or pseudophakic eyes, and it is considered to be the second line of treatment for malignant glaucoma if medical therapy fails to deepen the anterior chamber and lower intraocular pressure within 5 days. This procedure releases the trapped aqueous from the vitreous cavity, and multiple large openings need to be done peripheral to the IOL optic. Laser photocoagulation of the ciliary processes, either transscleral or through an LPI, has also been described as a treatment for malignant glaucoma to induce shrinkage and posterior rotation of the anteriorly rotated ciliary processes. Surgery for malignant glaucoma is indicated after medical and laser therapy fails. The definitive surgical treatment for malignant glaucoma is pars plana vitrectomy along with anterior hyalerotomy, zonulectomy and iridectomy, and this is said to create a direct communication between the vitreous cavity and the anterior chamber, thus resulting in an unicameral eye without functional separation into anterior and posterior segments. And this procedure has been found to be more successful in pseudophakic eyes as compared to phakic eyes. So in phakic eyes, it is recommended that this procedure should be combined with phacoemulsification and IOL implantation. Following an episode of malignant glaucoma in an eye, the fellow eye is at risk of malignant glaucoma following surgery. And in these eyes, an LPI should be done and is a must before any intraocular surgery. And to further reduce the incidence of malignant glaucoma, lens extraction along with vitrectomy can be performed prior to performing glaucoma surgery, followed by long-term administration of atropine. Uveal effusion can also cause secondary angle closure glaucoma by a posterior pushing mechanism, and in uveal effusion there is accumulation of fluid or blood in the potential space between the uvea and the sclera. Causes of uveal effusion include idiopathic uveal effusion syndrome, nanophthalmos, drugs, surgery, inflammation, trauma, tumors, and retinal vein occlusion. These factors can cause glaucoma by multiple mechanisms and will be discussed in the following sessions. Nanophthalmos is an unusually small eye with a short axial length of less than 20 mm, high hyperopia of more than 7 diopters, and a small corneal diameter, but is otherwise normal in shape and structure. These two figures actually define nanophthalmos. In a nanophthalmic eye, the relative volume of the crystalline lens is higher than in a normal sized eye, and the sclera is thick, which tends to compress the vortex veins. Nanophthalmos is an inherited condition and can be syndromic or non-syndromic. Because of the shallow anterior chamber, nanophthalmic eyes are prone to primary angle closure, but nanophthalmic eyes are also prone to uveal effusion and associated exudative retinal detachments following intraocular surgery or even spontaneously. In a nanophthalmic eye with glaucoma, glaucoma should be managed with medical and laser treatments, and every attempt should be made to avoid surgery, and this is very important to remember. If intraocular surgery is required in a patient with nanophthalmos, prophylactic posterior sclerotomies are indicated to reduce the incidence of intraoperative uveal effusion. Removal of the lens and anterior vitrectomy should also be considered to minimize the posterior pushing force. If choroidal effusion develops intraoperatively, these sclerotomies help to drain the fluid in the suprachoroidal space through the sclerotomies and outside the eye. Surgical procedures such as scleral buckles, vitrectomy, and laser procedures can cause glaucoma by a posterior pushing mechanism. Scleral buckles, particularly encircling bands, can directly narrow the angle, cause anterior rotation of the ciliary body and the ciliary processes, and cause compression of vortex veins leading to uveal effusion. In angle closure glaucoma due to scleral buckles, typically the peripheral iris is flat and central depth of the anterior chamber is adequate, and this usually responds to medical management with cycloplegics, aqueous suppressants and steroids within a few days, else readjustment of the scleral buckle is required. Panretinal photocoagulation can cause uveal effusion leading to ciliary body thickening, anterior rotation of the ciliary body, and annular anterior choroidal detachment. It usually resolves in a few days with medical management with cycloplegics, aqueous suppressants, and topical steroids. Following vitreoretinal surgery, vitreous substitutes such as air, gas, or silicone oil can push the lens iris diaphragm anteriorly significantly, and this can be prevented by performing an inferior peripheral iridotomy. Gas and silicone oil is lighter than water, and so when the patient is in an erect posture, gas or silicone oil will float upwards and will allow fluid in the posterior chamber and the posterior segment to escape into the anterior chamber through the inferior peripheral iridotomy. But if that doesn't help, removal of silicone oil or glaucoma surgery will be required. The drug topiramate is commonly prescribed for epilepsy, migraine, idiopathic intracranial hypertension, and depression. And topiramate can cause an acute onset of bilateral myopic shift along with bilateral angle closure within 1 month of initiating the medication, and this occurs due to ciliochoroidal effusion. And in such a situation, the patient presents with sudden onset of bilateral blurring of vision, ocular pain, and headache. And we'll find uniformly shallow anterior chamber involving both the central and the peripheral portions of the anterior chamber as shown in these two photographs. The IOP is usually significantly elevated. An ultrasound biomicroscopy and B-scan will detect ciliochoroidal effusion. The UBN picture shows ciliary and anterior choroidal effusion 360 degrees around the eye, and B-scan shows a shallow choroidal detachment. Other drugs which can cause angle closure by a similar mechanism include acetazolamide and midazolamide, trimethoprim sulfamethoxazole, bupropion, and the psychedelic drug MDMA or ecstasy. Treatment of drug-induced uveal effusion includes immediate discontinuation of the provocating drug, administration of cycloplegics and aqueous suppressants, and with this treatment following topiramate-induced uveal effusion, it has been seen that angle closure is usually relieved within 48 hours and myopia resolves within 1 to 2 weeks. Large bullous exudative retinal detachments can cause secondary angle closure by a posterior pushing mechanism. In retinopathy of prematurity and persistent fetal vitreous, also known as PHPV, contraction of retrolental fibrous tissue can cause secondary angle closure glaucoma by a posterior pushing mechanism, and in ROP, neovascular glaucoma can also contribute. To recap the salient points, in malignant glaucoma, secondary angle closure occurs by a posterior pushing mechanism. The ciliary body rotates forwards and apposition of the ciliary processes either with the crystalline lens or the anterior hyaloid face blocks the flow of aqueous anteriorly into the posterior and anterior chambers. It typically occurs following glaucoma surgery in an eye with a history of angle closure and can occur immediately or months following the surgery. Less commonly, it can also occur following other forms of surgery and even spontaneously. Patient presents with headache, eye pain, redness, and blurring of vision. On examination, the anterior chamber will be found to be uniformly shallow both in its central and peripheral portions. The intraocular pressure will be found to be elevated, and if an LPI had been done previously in that eye, the peripheral iridotomy will appear to be patent despite the presence of a shallow anterior chamber. In the early postoperative period, malignant glaucoma needs to be differentiated from pupillary block, choroidal effusion, and choroidal hemorrhage, all of which present with shallow anterior chambers. Management includes atropine, which is very important to remember, laser peripheral iridotomy to relieve any associated pupillary block, and aqueous suppressants to lower the intraocular pressure. If intraocular pressure is found to be significantly elevated, hyperosmotic agents can be administered to dehydrate the vitreous. 50% of patients with malignant glaucoma recover with this medical therapy. The remaining require other procedures such as laser posterior capsulotomy with anterior hyalotomy or surgical vitrectomy, hyaloidectomy, zonulectomy, and iridectomy. With or without surgery, atropine needs to be continued long term in these patients. Fellow eyes in patients with malignant glaucoma are prone to develop malignant glaucoma following intraocular surgery. Uveal effusion causes secondary angle closure glaucoma by anterior rotation of the ciliary body, which results in posterior misdirection of the aqueous into the vitreous cavity which pushes the lens iris diaphragm forwards. Ultrasound biomicroscopy shows ciliary body and annular anterior choroidal detachment as well as a shallow anterior chamber. And B-scan ultrasonography shows shallow detachment of the posterior choroid. Causes of uveal effusion include idiopathic uveal effusion syndrome, nanophthalmos, drugs, surgery, retinal vein occlusion, trauma, and uveitis. Nanophthalmic eyes with axial length less than 20 mm are prone to develop uveal effusion following intraocular surgery. Surgical procedures are better avoided in these patients, but if required, prophylactic posterior sclerotomy should be done intraoperatively. Panretinal photocoagulation and scleral buckling can also lead to uveal effusion. Vitreous substitutes such as silicone oil and gas injected following vitrectomy can push the lens iris diaphragm forwards. Drugs such as topiramate can cause bilateral uveal effusion. Patient presents with sudden onset of bilateral acute myopic shift and bilateral pain and blurring of vision within 1 month of initiation of the drug. Treatment is withdrawing the drug and administering atropine. Thank you for listening.